Okay, thank you. So thank you for having me and for accommodating an online talk. I'm sorry I can't be there in person. I've had clinical duties today that I've not been able to get out of. I'm going to be presenting on the promise of handheld point of care devices for diagnosing snake bite coagulopathy. And these are results from a scoping review that's in press at the moment and should be published in the next couple of months in the journal Thrombosis and Hemostasis. So just to give a brief bit of background, so VICC, venom-induced consumption coagulopathy, as we all know, it's caused by many medically important snake species, particularly the Vipiridales, and it often coexists with endothelial disruption caused by the snake venom metalloproteinase enzymes. And the combination of blood vessel breakdown and coagulopathy poses a risk of bleeding, which has a spectrum of severity. And the worst case scenario is shown on the slides here. So these are from the same patient. This CT scan shows an intracerebral bleed. These white areas are areas of blood within the brain. And this was, of course, fatal. And the post-mortem sections are shown here, where you can see the bleeding into the parenchyma of the cerebrum. However, the majority of patients, so in this example from Nigeria, 60% do not have any signs of bleeding, either minor or major bleeding. And therefore, we rely on diagnostic tests to diagnose VICC in these 60%. And commonly, this is the 20-minute whole blood clotting test. And as per the WHO guidelines and many other recommendations from other groups, this is an urgent indication for administering antivenom. The reason that we use the 20-minute whole blood clotting test is that it's a simple, pragmatic bedside test that can be done in low resource and rural settings where snakebite tends to occur. It was developed by David Worrell in a paper published in 1977, I believe, and is similar to the Lee-White method, which was developed in 1913, which is also used in snakebite in some settings, but certainly the 20-minute whole blood clotting test is the more widely used and accepted test. And in a recent meta-analysis conducted by Tom Lamb a few years ago, the test is fairly accurate, with 84% sensitivity and 91% specificity compared to an INR gold standard. So as well as measuring coagulopathy to manage snakebite clinically, it also has relevance as a trial outcome measure. And recently, in the development of a core outcome set for snakebite clinical trials, there was consensus that INR should be measured in future snakebite clinical trials of coagulopathic snake species. But within the development of this core outcome set, there were members that held strong views that lab INR is too challenging to implement in low resource settings. And that prompted really this scoping review to look at point of care tests as a potential alternative of providing a standardized test that could be used in remote rural settings where lab facilities are not available. So we conducted a literature research of the available evidence on point of care devices, and then searched for all the commercially available point of care devices that we could find and shortlisted the most promising for validation in future preclinical and clinical studies. And so to date, there's been 4 published papers on point of care devices in snakebite. These first 2 conducted in Australia are case reports with a sample size of 1 each. And then the latter two are a small prospective study in Australia with 15 participants, and a small prospective study in India with 18 participants. And these assessed INR point of care devices, including the iStat device, CoaguCheck, and the INR ratio 2, which has since been discontinued. And all of these studies found that point of care INR resulted in false negative results. And there's a summary of those results here. So these have been pooled for each snake species. So this is the Russell's viper, this is Australian elapids pooled together, and this is Echis carinatus. Each vertical line is an individual participant, and the blue line represents the gold standard true INR from a lab INR result, and the colours represent each individual point of care INR. And you can see that regardless of the level of coagulopathy, the point of care devices universally give low results, even when the lab INR is above the upper limit of detection. The exception is these three with Echis carinatus envenoming, but you can see that the lab INRs in these patients were low at 4 or less, whereas in Echis envenoming, we often see undetectable INRs. And obviously this sample size is small. So it doesn't look good for point of care INR devices based on this. And why may these devices be failing? So if we look at the coagulation cascade, and specifically the part of the cascade where INR is relevant. So the extrinsic pathway is activated through the addition of tissue factor, which activates factor 7, which activates factor 10, which activates prothrombin to thrombin, and then thrombin degrades or cleaves fibrinogen into fibrin, which forms the clot. And in a lab INR, tissue factor's added, and then you just time how long it takes for the fibrin clot to form, which is usually measured by the plasma becoming more cloudy and causing a change in absorption signal. Where the point of care devices tend to differ is that they rely on a thrombin substrate, which is cleaved by activated factor 10, and that produces an electrochemical signal. And so the point of care device ends measurement here, whereas the lab device ends its measurement here. And this is important because in snakebite, the hallmark of VICC is breakdown of fibrinogen. And so that is captured by a lab INR and missed by some of the point of care INR devices. I say some devices because there are actually certain point of care devices that do measure fibrin clot formation rather than relying on a thrombin substrate. And they have not been assessed in clinical studies to date. So if we move on from INR to fibrinogen quantification, which seems like a promising thing to measure because we know that for many medically important snake species, fibrinogen consumption is a hallmark of VICC. And this is typically measured in the lab using the Klaus method, where thrombin is added to the sample and the time is measured for the fibrin clot to be formed. And this has been miniaturized in a new point of care device that has come out in the last year or two, called the QLabs Fib system, which is shown here and which I believe Amy Marriott talked about briefly yesterday. And this device has been approved for use in obstetric hemorrhage in the UK, and I believe it's also approved in other European countries and Australia. It's not approved in the USA, where they tend to rely on thromboelastography instead. And this validation study that was conducted compared the gold standard Klaus lab-based fibrinogen method against this point of care device on stored samples. And there's good agreement between the two results. So The final part in the clotting cascades, which can be considered to diagnose VICC, is the measurement of fibrinogen degradation products. So plasminogen is in the circulation and is breaking down fibrinogen and fibrin and cross-linked fibrin to form different fibrin degradation products, including D-dimer. And D-dimer is relevant because that is a routinely available test that's widely used across healthcare settings to diagnose blood clots such as deep vein thrombosis. And there's many point of care devices out there that can measure D-dimer. One slight concern is that the thrombin-like enzymes of certain snake species bypass the formation of cross-linked fibrin. They directly break down fibrinogen to form a soft, non-cross-linked fibrin clot. And when this soft clot is degraded, it will not produce D-dimer. So there's a theoretical possibility of false negatives with D-dimer rather than measuring other FDPs. Nevertheless, a recent study by Jeff Isbister in Australia found that D-dimer is an accurate marker of VICC. So we shortlisted the devices, and I've given an overview of this here. So there were 7 available point of care INR devices. 1 was very expensive. 4 relied on a thrombin substrate endpoint and were excluded. And 1 had a control assay that relied on technology that would fail in the presence of low fibrinogen. And Amy Marriott confirmed this in her in vivo research. So that device was excluded as well. And that actually only left 1 device, the CoagSens, for prioritization for future validation studies. There's a clotting assay that I've not talked about, the APTT. There's only 2 devices that measure this, and 1 is very expensive at over almost £20,000, and the other relies on a thrombin substrate, so they were both excluded. The point of care fibrinogen device, there's only 1 commercially available. That's the QLabs Fib system. And then D-dimer, there's many devices that are binary and give us a yes/no result for raised D-dimer. But for snakebite, a quantitative test is needed, and there's only 3 that do this. 1 of these has been shown to produce a false negative result in a previous case report in Australia. So we felt the PL Mini handheld and the Lumira DX device should be prioritized. And then just to provide a sample of some of Dr. Marriott's data, where she has been able to assess some of these devices in the mouse model and found promising results. So this is for the QLabs Fib system. This is the mouse data that Dr. Marriott has presented. Following envenoming and without treatment, there's a fall in fibrinogen to the lower limit of detection, and fibrinogen remains low throughout the duration of the experiment. Whereas with treatment, with pre-incubation treatment, there's a transient fall and then a recovery of fibrinogen to near normal levels. And if we compare that with human observational data, this is data from Mion from Djibouti of Echis envenoming. The patients in red had been envenomed by Echis and not treated with antivenom, and their fibrinogen levels were low and remained low for a number of days, whereas those treated with antivenom have a rapid recovery in fibrinogen. And so these data seem similar, and this seems reassuring that the QLabs Fib system may work in human envenoming. So on a related note, something we identified during this scoping review is a test called the activated clotting time. So this is widely used during cardiopulmonary bypass surgery, and this is from the 2019 European guidelines, where it's recommended to monitor the effect of heparin. So patients are given high doses of heparin to stop their blood clotting as it passes through the bypass machinery. And therefore, this is a standardized, validated test. that's in routine use. It's very simple. It's similar to the 20-minute whole blood clotting test, but the difference is that the tube contains either Celite or kaolin, which are potent activators of the clotting cascade. And they're also in powdered form, so they have a high surface area. And the sample will clot more rapidly. It tends to clot in 2 minutes. And the detection of that clot can be visual, similar to the 20-minute clotting test, or it can be through automated detection. So it's hard to see here, but these tubes have a small magnet within them, and the movement of that magnet can be measured and used to standardize the endpoint read of when a clot has formed. This image is kaolin, so it's a clay mineral, and has almost negligible costs. And there's an interesting dissertation that was that's available online. It hasn't been peer reviewed, but it gives a very detailed overview of experiments conducted by Shenoy and colleagues in India, where they compared the ACT, which they called the velour manual activated clotting time, with INR and with the 20-minute whole blood clotting test. And they found that the ACT method has 94% sensitivity and 97% specificity to predict an INR, and was slightly superior to the 20-minute clotting test. Other advantages of the ACT method are that it's better standardized. The result is available slightly more quickly. It still is affordable, and it seems to be quantitative. So this graph from Shenoy's work shows VMAC time, or ACT. So this is the time for the clot to form on the x-axis, and the INR result. And there seems to be a good correlation between the two. So finally, I'll talk about the cost considerations, which is very important in the field of snakebite. And unfortunately, these point-of-care devices are quite expensive. So the CoagSense device is $1,100 for the device, and approximately $1.50 per test. The QLabs is more, it's $1,900 for the device and $21 per test. This is a very new device, so that's probably why the costs are high at the moment. So for clinical use, although they might have a role in high and middle income settings, they're too expensive to be used in low resource settings, unfortunately. There is a potential cost-effective argument to be made, as these tests could be used to better distribute antivenom, and antivenom in and of itself is very expensive. So there may be indirect savings. In terms of the relevance to clinical trials, these point-of-care devices are much less expensive and less logistically complicated than setting up and maintaining laboratory facilities. And they also provide a fair, well, they have the potential to provide a fairly sensitive outcome measure. And that's important because a more sensitive outcome measure will increase the power, the statistical power of a trial, and reduce the necessary sample size, which has a significant impact on the trial budget. And then finally, the activated clotting time has almost negligible costs. So looking through our purchasing system at LSTM, a kilogram of Celite can be purchased for less than £20. And that would be enough for many, many thousands of tests. So in conclusion, point-of-care devices do seem promising, and in particular, the QLabs FIB system and the CoagSense INR device should be prioritized, we believe. The ACT method also seems promising and should be assessed as a potential alternative to the 20-minute whole blood clotting test. And we're working with partners in Brazil, Ghana, and Sri Lanka to hopefully undertake validation studies in the near future. And we would encourage others to do the same and to explore the potential promise of these devices. So I'll end there with thanks to everyone who's been involved and everyone who is involved with the planned validation studies in the future. Thank you very much.